So this is a case that one of my gastroenterologists showed me. It was really cool. I had never heard of it until very recently. So this patient had a real wide gastric bypass, came in with CVD stones. And so typically what they would do is, like they do like a percutaneous transhepatic, biliary access, and then try to get the CVD stone. But now they can do this new procedure where they go in endoscopically. And this is what we're seeing here. There's the endoscope. And then they put this axios catheter between the excluded stomach and then the pouch. And here's the magnified version of that. This is what it is, the axios. This is what it looks like. It opposes the two walls, and they typically do this for like cysgastrostomy for patients with walled-off necrosis in the setting of like pancreatitis. But now this has really opened up options for GI interventions, for example, with CVD stones. So here is the cartoon version of what it looks like. So this is a patient with a Roux-like gastric bypass. They create this basically a fistula with the axios catheter between the gastric pouch and the excluded stomach. In this cartoon, they're showing drainage of the walled-off necrosis from pancreatitis. But now, because they can now create this communication, they can access the CVD system. So now they can avoid percutaneous access, and sometimes they used to have surgical intervention for dealing with CVD stones. But this has really opened up more options for them. I hadn't heard about it until very recently.
Nelly, that's super cool. We have lots of questions.
Oh yeah, go for it.
One, doesn't that then not make your gastric bypass effective, or do they try to close off that gap, the hole between the two stomachs later? Or
yeah, they can take it out.
Okay, and then I know sometimes. Mm-hmm.
It just seals off though, because wouldn't that just create a GG fistula if you don't do something actively to close that gap?
In terms of what they do after, I'm not quite sure, but I know they do take it out. Like, for example, after our percutaneous, not percutaneous, but the cysgastrostomy for walled-off necrosis, they take it out. They remove it once it's drained. So
right, but for the walled-off necrosis, they you have that collapsed cavity, so you're basically making you have a communication with a walled-off cavity.
Yeah, no, that's a good question. You can have a persistent, fistulous communication, for example, between the excluded stomach and the pouch. So I'm not sure if the patients gain the weight back, or this is a relatively new procedure and we've only done 3. So I don't know that we know the long-term sequelae.
Nelly, that's cool. So here, sometimes they'll try to do a rendezvous procedure where they go all the way down the Roux limb, and then they go back up the other side, but they had such a high failure rate that they started doing a combined laparoscopic endoscopic approach, which yours is similar to what you're talking about, but ours, they basically went in laparoscopically and made a hole in this duodenal loop and then put the scope in. And then the surgeon puts a hole, then the endoscopist puts their scope in, they get out the stones, and then the surgeon laparoscopically ties off the hole.
Mm-hmm. Yeah, no, yeah. So this is a little bit less invasive.
Yeah, probably just eventually.
I'm surprised I haven't seen that yet here.
That's because we're cool here.
Okay.
Just kidding.
Well, they get to New Mexico, maybe.